All right. Well, good afternoon, everyone. Thank you again for joining us as we kick off the fall series of the MAPP Rounds. So today we have the pleasure of hearing about Dr. Franzen's research. And just as a reminder, please add your questions and comments to the Q&A. We'll leave them for the end, but you can add them as they arise. So Dr. Franzen is a neuropsychologist and researcher who works at the Alzheimer Center of the Erasmus University Medical Center in Rotterdam in the Netherlands. And her research interests lie in the development of neuropsychological tests for culturally, educationally, and linguistically diverse populations, as well as in initiatives that aim to improve dementia care and access to research in these underrepresented populations. Between 2015 and 2021, she helped co-found and coordinated the Multicultural Memory Clinic of the Erasmus Medical Center, and she's also the co-founder of the European Consortium on Cross-Cultural Neuropsychology. So welcome, and you can take it from here.
Thanks for that introduction. Yes, I'm very excited to be here, and I hear that I'm kicking off this new season of these new rounds, so I'm really excited. Let me just share my screen with you so you can watch my presentation. I think that should look good now.
Yes, we can see it.
Perfect. What I'll be talking about today is mainly the topic of my expertise. So that is neuropsychological assessment of diverse older adults in Europe. So let me remind you, my name is Sanne Franzen, a common name in the Netherlands, but not very common elsewhere. And yes, I'm a neuropsychologist and a researcher in our center. So what I'm hoping to talk to you about today is first, just to give you some background about diversity in Europe, because I think it's always necessary and important to hear a bit more about the context of the people that we're talking about here in our research. Then I'll be moving on to some of the barriers that we experience in neuropsychological assessment in these diverse populations. And I'll move on to discuss the formation of our European Consortium on Cross-Cultural Neuropsychology, or ECRON. And I'll do that by providing quite some examples of tests that were developed here in Europe. And I would also like to highlight some gaps that I think really need to be filled still for the field to continue. I would also like to briefly touch upon dementia prevention in diverse populations, as we have some experience in that area as a center. And if time permits, after questions, I might have some bonus material available because I always ramble. I never really know when I run out of time. So perhaps I'll get around to that today, or perhaps not. Okay, just to give you some background about cultural diversity in Europe. So in Europe, we've seen several different waves of influx of people coming from all sorts of regions across the world. And this sort of began with the influx of people that lived in former colonies when these countries gained their independence. So in the Netherlands specifically, that's, for example, the former Dutch East Indies, currently Indonesia, but also, for example, Suriname used to be a Dutch colony. Same goes obviously for the UK. You've seen the news, I think, with Queen Elizabeth passing recently. And some form of migration that happened after this period is a time of labor migration. So when the European economy really started to boom after the Second World War had ended for a while, we had a lot of need for people to work in our country. So that's why a lot of people were recruited from different areas to do mainly low-skilled labor. After that, there followed a period of family reunification of mainly the spouses, but also the children of these labor immigrants. And also we saw an influx of refugees and asylum seekers in in different eras in the last decade. And most recently, for example, we've been experiencing an influx of people from Ukraine. We also have some indigenous populations in Europe, although they may not be as well known. For example, in Scandinavia, we have the Sami population, which is more and more getting integrated, I think, with Scandinavian populations that are not indigenous, but just to give you an idea. And we have some scatter populations, for example, the Roma or traveler populations. And to give you an idea, for example, at the peak of the immigration, you could see that quite a large percentage of the people living in these specific countries, West Germany still existed then, consisted of people who came as labor immigrants. And many of these people actually stayed in these countries instead of going back after a certain number of years. And this was quite contrary to expectations, both on behalf of the host countries, but also for the people coming here themselves. And I think it was mainly that was one of the reasons why the local governments didn't really invest in programs to have people learn the language or really acculturate or mix with the host country culture. And what you see is that there were a lot of like smaller communities being formed within our countries in Europe. And what we know is that low education and illiteracy is quite common among some of these diverse demographic groups in Europe. So for example, here in the Netherlands, we know that over 80% of the female Moroccan first-generation immigrants really have had no formal education at all. So they're not able to read and write generally. So I think when you're thinking about dementia, that is obviously a big risk factor for dementia. And we also see that there's a higher prevalence of dementia in quite a few demographic groups here in Europe. So for example, in this graph that I'm showing you here, you can see elderly individuals who were born in the Netherlands in the green line. And for example, you can see people with a Turkish migration background in black. And people with a Moroccan background in red. So there's quite an increased prevalence of dementia in some of these specific subgroups. And we think this is likely due to increased risk factors such as cardiovascular disease, diabetes, but also low education levels in some of these groups. And so you can imagine with this enormous diversity that we really had to find a way to accommodate all these different patients with different backgrounds, different languages, and different levels of education in our clinics. And that also means that our neuropsychological tests had to be applicable across many different languages and cultures, which is quite a challenge in daily practice. One thing I think that is helpful in Europe is that access to care is relatively good, at least in Northern and Western Europe. And as you can see here on the figure on the right-hand side, the countries in green are countries where there's some form of universal healthcare. And as you can see, most countries in Europe do have that. So that means healthcare in general is quite accessible to a lot of the people who might want to visit a memory clinic, for example. And I think that's helpful, especially also seeing that cost of healthcare does not take up a very large part of people's general incomes in Europe in general. Obviously, there's going to be individual differences there. However, even though access to care is actually quite good, we still find that, for example, issues in dementia awareness can really delay the time until patients with a diverse background reach a diagnosis. So, for example, some cognitive symptoms of dementia may not be recognized in all people. You can see me here when I was doing some dementia education in a local mosque. And what we really found was that people would recognize behavioral impairment and behavioral changes as part of dementia, but not necessarily forgetfulness or a decrease in attention. And it was mainly only when people really felt that behavioral problems got out of control or dangerous situations started to happen, that they sought care, for example, in the hospital. And at that stage, mostly it was hard to determine what was actually causing the cognitive and behavioral problems, because the dementia was already progressed quite a bit. Another thing that we need to take into consideration is that we can encounter a lot of different explanatory models about dementia. So one thing, for example, that does occur here is that people may think that someone with dementia is actually possessed by evil spirits called jinns. And the idea is that you would go to some form of a healer, like a spiritual healer or someone, to exorcise those spirits, and not necessarily to a hospital. But I've also encountered lots of people who don't consider dementia as a disease at all, and see it as normal aging, and not seek any care for that reason. And I've also encountered people saying, like, oh, he had a very stressful life, maybe there were lots of deaths in the family, or someone had to do hard labor, and that directly caused the dementia. And even though a stressful life can contribute to dementia, it's probably not a one-to-one connection with dementia. But these are some of the explanatory models that we do see in our clinic. One other thing I think is important to take into consideration with some diverse patients is that they may have widely different views and expectations about healthcare. So for example, this photograph here on the right is taken in a hospital in Ankara in Turkey, where we went for a work visit. And we noticed that there were so many lines there in the hospital, and it turned out you can actually choose whom you will be referred to, or actually you're self-referring. So if you think your problem is neurological, you will go to a neurologist, and there's no one to sort of help you out and find out who to go to. And there's people waiting there in line, and then maybe they have to come back the next day because consultation hours are over, and they actually didn't make it into the consultation room. So that is something to take into consideration, as well as, for example, patients being accustomed to accessing more services if they pay something extra, sort of like a secret transaction. And these are all things to sort of keep in mind, I think. So in the Netherlands specifically, we try to really have a few expert centers that are sort of accommodating these patients specifically, given that our country is quite small. So the travel distances are not too great. So the first few large multicultural memory clinics in our country came to exist in the major cities such as The Hague, Rotterdam, and Amsterdam. Although I've been getting requests more and more from across the country showing that, not everyone will be able to travel to these specialized centers. And what we do know is that in the larger cities, the population is extremely diverse. And this really shows in our data. For example, we saw patients with 50 different nationalities over the course of 4 years. And many of them are bilingual in any language, or they're multilingual, speaking multiple languages to a different degree. So that's quite diverse and quite a challenge as well for us. And what we try to do in these big multicultural memory clinics is we always have a consultation with either a geriatrician or a neurologist, and we try to conduct a thorough neuropsychological assessment, which I will talk a bit more about later. We use a history taking or an intake with a cultural interview or cultural formulation interview that is part of the DSM, and we use a slightly adjusted version of that. In our center specifically, we have trained and paid medical or paramedical students who are bilingual and mostly also bicultural, who can serve as interpreters, although we also hire professional interpreters from a national agency that we luckily have in the Netherlands. We use widely applicable neuropsychological tests in our neuropsychological assessment. And obviously, as is the case with any other type of patient, we make use of other biomarkers such as imaging or cerebrospinal fluid if it's necessary. So one thing that I think most of my research has focused on over the past few years is how to work around the barriers that we run across when we're doing neuropsychological testing in these very diverse populations. So one of the first obvious things I think is that a lot of tests that we traditionally use have very culture-specific items. So for example, these are two items from the Boston naming test, the pretzel and the igloo. In the Netherlands, the pretzel is actually a cookie, a sweet cookie that a national cookie that we have, which is called a krakeling. And a lot of patients don't know that, obviously. So we will have patients say pretzel, especially when they're from, further away. But it became a challenge when people would say it's a snake, for example. That doesn't really seem correct, probably. But how can we really know if someone may never have seen this item before? And it gets more challenging even when you're looking at the igloo, for example, because someone who's never seen snow in their life might actually say this is like a traditional brick oven. And I actually think that's quite a good and clever answer when I think about it. So these very culture-specific items can really be a challenge. And we also know that black and white line drawings can be really difficult for people with low education levels to sort of recognize, name, but also to remember. Another aspect that we run into is that most 3D sort of drawing tests can be quite complex for people with low education levels. So some of the figures you see in the middle are drawings made by healthy but illiterate Turkish immigrants. Some of them from my colleague Rune Nielsen in Denmark, and some of them are from my patients. And what you'll notice is that there's very varying levels of ability to render that 3D aspect, but also just to have those very clean angles. Because many patients are just not accustomed to use a pencil. And you can even tell that sometimes when patients are not using the correct grip of a pencil, as you see in the bottom picture. Another thing I think that's very important is that in a lot of cultures, doing something as well as possible means you do it slowly. So in a lot of Western cultures, we learn through the education system that speed and being quick is sort of equal to being intelligent, but that's not the case for a lot of other cultures. So this is something that's making it very difficult to measure attention and mental speed in diverse populations. Other stuff that we run into is, for example, abstract questions that, require a specific way of conceptual thinking that may not be shared between different cultures. Or even I had a patient who thought that their doctor was quite confused or stupid because he was asking him all these easy questions about the date or the year, because he actually suspected that the doctor didn't know those things and was asking him for that reason. So those sorts of surprising things can happen sometimes. And I think it's also quite clear that not all of these tests have a clear link to the issues that people are experiencing in daily life, which is what we call ecological relevance. And that can mean that some people who aren't used to being tested don't really feel motivated or they don't really understand why they have to do these tests. So these are some major barriers that we run into. So actually, I once did a review and I found that there's quite a limited number of tests that are really suitable for low educated diverse populations to determine whether they have dementia. I think one great example is the trail making test, where even when you're looking at Italian, for example, you start to notice that there's already some linguistic issues because they don't traditionally use the letter J. So if you administer the regular trail making test, you'll find that it doesn't work because a letter in the alphabet is missing. And for Arabic, for example, there's 3 different ways to display letters depending on the position of a letter in the word. So that makes it quite challenging to devise a good trail making test in Arabic specifically. Another linguistic effect, for example, is that We know that digit span is very much influenced by language, because the shorter the sounds of the numbers are in your language, the more information you can retain in your phonological loop, in your auditory memory. And for example, another study found that verbal fluency is highly influenced by education / literacy, probably more literacy. But that's not the case for all types of semantic verbal fluency tests. So if you ask people to generate supermarket items, it's quite doable, even if you're, if you do not have a high literacy level. But for example, for animal fluency, you might encounter that patients run out of words to say because the number of animals that they've actually encountered personally are quite limited. So we weren't the only ones who ran into these barriers and these issues and who wanted to see if we could address this in the future. So that's why in late 2019, we founded this European Consortium on Cross-Cultural Neuropsychology. And we tend to meet about monthly to bi-monthly, and it started off really small with a few countries, but slowly, over time, we start to really organize, I think, as a continent. And there's people working in different fields. So there's also people here working in child neuropsychology, for example. But we're working on these topics together. And if you're interested about reading that in more detail, I sort of on behalf of the consortium wrote a position paper that we all drafted together about our ideas for the future and also our standpoints, I think, from a European perspective. And in the next few slides, I would like to take you through some of those to give you an idea. So one of the things that we are really passionate and excited about, and one thing that's already been done a lot in the United States, is to really dive more deeply into those diversity-related variables, such as acculturation, bilingualism, ethnicity, all those sorts of factors. Because that has not been done very much in Europe in cognition research. And there's actually a reason for that. For example, when you're looking at acculturation, there's different ways to measure that. So one of my colleagues adapted the BASH, which is actually an acculturation scale used in studies of people with a Hispanic or Latina origin in the United States. I'm saying Hispanics because it's in the title, but I know different terms are being used now. Some people will look at years of residence in a specific host country or the proportion of life that they've lived in that specific country. But there's also cultural distance measures that are increasingly being used in Europe, for example, to determine if there's a large difference between a patient, let's say, who's assessed in Denmark, who's from Sweden, versus someone who's assessed in Denmark, who's actually from, let's say, Kazakhstan. So you would imagine the cultural distance would probably be bigger in those cases. And just to get back to that, there's no final word yet about which of these measures is actually good and helpful. Whereas I think in the US, there's already been quite a bit of research going on in this area. For example, the recent paper about different acculturation measures, for example, like familism, and seeing how they relate to cognitive test performance in dementia. And so looking at quality of education is also quite difficult because, for example, I tried to develop a literacy screening tool for a few different languages, but you have to keep in mind that we have so many different nationalities here that it's no mean feat, I have to say. We sometimes use some type of self-report and also look at the place where their school was, whether it was a rural or an urban school. But a lot of the indicators that are frequently used, for example, in the US to determine the quality of someone's education really aren't available, such as data on someone's classroom size, student to teacher ratios, length of the school year, but also good tests that can measure reading level, for example. So we have a long ways to go before we can figure out the quality of people's education, which is really important given that that is probably very variable depending on where people came from and and what their access was to quality education as well. Another one that's still very challenging to measure is language proficiency. So in all of Europe, bilingualism and multilingualism is very common, not only in people who came as immigrants to the EU, but also people within the EU tend to speak more than one language. And like me, for example, I speak Dutch. That's my native language. I learned English when I was in school, but I also am able to speak a little bit of French and a very, very poor bit of German. And it's actually quite hard to measure proficiency in other languages, particularly those that are not very highly standardized or local dialects. So for example, I'm often seeing patients who speak Moroccan Arabic, which is a dialect of Arabic for which there's not really any easy tests available to determine someone's proficiency very precisely. We also know that language and the impairment that you may have in language also obviously depends on how often you use a language. So even if you used to be very proficient, if you're not using a language much, it can still mean that it may degrade over time, or it takes a while for you to get back into it. I had a patient A, but this is an old slide, so I was thinking, I remember. This patient of mine, he originally came from Turkey, but he lived in a city that was very close to the border region with the Arabic-speaking part of okay, I forgot the bordering country to Turkey. It doesn't matter. At least, so in school, he had to speak Arabic. At home, he used to speak Turkish, but he moved to the Netherlands when he was in his late teens. And here he really became quite proficient in Dutch. And he also had some French in school. And so I tried to ask him, what is your preferred language for testing? And he wasn't even sure if he was able to do all the testing in the same language, because some words he really learned in school when he was speaking Arabic. Some stuff was really, built when he spoke Turkish at home, and other phenomena he really encountered only when he arrived in the Netherlands. So in the end, we sort of did a mixed assessment in different languages, but I think that showcases how difficult it may actually get in these clinical settings. So a second thing I think that ECHRON is really excited about is working on more widely applicable tests instead of trying to collect race-based norms specifically for different groups. I think it's a good thing to know that the word race in itself has been really tightly connected for a lot of people in Europe with the Second World War. So that means we don't really like to talk about race as a concept at all. And we also feel that it's more important to take into account those different aspects of diversity rather than to just stratify based on race only. I think it makes more sense to take into account different aspects of diversity at the same time in the same patient. And what we're hoping to do is develop tests that can be applied to a wider range of populations. Doing some easy improvements, for example, making sure you have colored items instead of black and white. Try and avoid skills learned in the educational system, like the figure copy. Trying to make tests applicable also to people with low education who are born in Europe, because those exist too, obviously. And we try to develop, validate, and implement these in our European collaboration. A final thing I think that we're all excited about is trying to improve clinical practice. And I note that training in neuropsychology is organized widely differently across Europe. And it differs a lot how long you should have had training to be able to call yourself a neuropsychologist. So it can be between 5 months, but also 60 months in total. And cross-cultural neuropsychology as a topic is often not a part of the curricula here in Europe. So we really feel we need to do some form of training, for example, in the form of a summer school. So let me next show you some test development initiatives that we've been working on. So this is some of my own work that we did in the Netherlands with the very commonly used tests of visual association memory that we often use to distinguish between patients with Alzheimer's dementia who really are impaired in sort of storing information in their memory, as opposed to people with vascular dementia who mainly have problems with retrieving the information that is already stored in the memory. And so normally you would have these kind of wacky associations between, for example, a monkey and an umbrella. And the next time you will only show the monkey and people will have to remember the object that was paired with that. And what we actually found when we were assessing patients with a diverse background and differing levels of education is that the black and white line drawings were a lot harder for them to remember than were the colored items. And this was actually the case even in the control participants in our study. So what you can see here in the graph is that for the controls, when we use the colored version, you can see that most patients reached close to a perfect score, given that it's quite an easy test with only 6 items. But on the figure on the right-hand side, which displays the result for the line drawing version, you can see that there's actually quite a few people who did not obtain a perfect score and actually got quite a bad score, such as a score of 3 on this test. So this really highlights the importance of using colored materials in people with low education level. We also tried to work on the assessment of naming impairment using our new test, the naming assessment in multicultural Europe. So we already knew, and I already told you, that the Boston naming test really isn't suitable for our diverse populations here. And that's why we decided to develop the name, in part based on the work by Alfredo Ardila, who did a lot of interesting work in this area. So we have a test now that includes 52 nouns in the categories nature, animals, objects, occupations, colors in the body. And also we included 8 verbs. And the idea is that all of these words are relatively widely recognizable across quite a high number of languages. And also that the items that we include are all relatively easy or relatively harder across languages. And I'm not going to tell you how we did that because it was a lot of work. And we did a first validation study in the Netherlands, but also recruited patients in Turkey. So we had about 40 control participants, about 60 Turkish patients who were living and were from near Ankara. And then we had 75 diverse patients from the Netherlands who originally came from 15 different countries and who were mostly assessed with a formal interpreter present. And of the patient sample, about 30 patients had Alzheimer's disease or a mixed Alzheimer's and vascular dementia. And we were hoping to be able to detect those patients specifically, given that they would likely have a naming impairment. So these are some of the items that we included in the test. Quite easy to recognize, I think, for most people, but we also really tried to make them look recognizable in terms of diversity. So really make it a test that is good for this population. We found that the test had excellent reliability, actually, and also robust correlations with the few other language tests that we have available for our diverse population. And what you can see in the violin plot, I'm not sure if you're very familiar with those, but what you can see is that patients with Alzheimer's disease or mixed dementia had quite lower scores than the other groups. So on 48 of the 60 items of the name in total, they had a lower performance, statistically significantly lower, with an area under the curve of about 0.88. And so I think that really helps us to sort of at least be able to pick up on naming impairment in patients with Alzheimer's disease, which so far had always been really challenging. And it was interesting that we found that the name scores were non-linearly associated with age and education. So for education, we saw that having a very limited number of years of education could really help increase your scores, and then the effect would taper off for higher levels of education. And for age, we saw something that is common in the literature where people would have a consistent score, you know, between ages 60, and then they would slowly start to decline by age 70 and after. So that they would have a sharper decrease in their scores after that age, which kind of makes sense, I think, when you're thinking about it. So we also did some research in screening instruments in diverse populations, and we examined the Roland Universal Dementia Assessment Scale from Australia, or the RUDAS, and also the Informant Questionnaire on Cognitive Decline, which is an informant-based questionnaire to try and figure out if there's cognitive decline over a longer period of time. And why we did some studies into this is that we know that there's a lot of bias in diagnostic tests such as the MMSE, particularly, for example, in our samples, because a lot of patients are illiterate, but also because of language barriers and cultural differences. So in one study in the Netherlands in diverse populations, they found that actually some or more of the items of the MMSE were skipped in 83% of patients with a migration background. And that was mostly due to either low education or limited test wiseness. And we also found that 82% of the healthy controls scored below the cutoff of 24 for dementia. So they were actually all misclassified as having dementia because they didn't have a lot of education and there were cultural barriers. And so the RUDAS is a good alternative. It looks very similar. There's an instruction video online that I would recommend you to look up. And it takes about 10 to 15 minutes to administer with some tests that are a bit more familiar, I think, to most patients. And it helps to supplement the RUDAS with the IQ code. It really helps to increase the diagnostic properties of the RUDAS if you're using it with IQ code. So we have some large test batteries as well developed in Europe. So the cross-cultural neuropsychological test battery, the CNTB of my Danish colleague, has a lot of different tests that I won't have time to talk to you in detail about, but it has a memory test with visual objects. It has color trails as an alternative to trail making. It has a 5-digit test example that's similar to a Stroop. It has clock reading, sort of for a visual spatial effect. Anyway, so it's very interesting. I would recommend you to look it up. And one thing I think that we've been thinking about a lot is feasibility of neuropsychological assessment. So in some really interesting work, I think by Meral Agvinian in South Africa, they really showed that test wiseness is so important in cross-cultural neuropsychology. So many patients, they really don't know what to expect. They might think you're going to do blood work when you're assessing them. They may think your tests are just games and it's nothing serious. Or they may have reactions to standardized testing that you're not aware of, such as anxiety about not finishing in time. And a lot of people will have different understandings of cognitive problems. So they may call them a fool or an idiot or a stutterer or someone who's mindless or crazy when you're describing someone with memory problems. So this is very important to keep in mind, I think, with patients with diverse backgrounds. And we also looked into that by doing a study among 345 of our diverse patients from the multicultural memory clinics across the Netherlands. And we used the Tulipa test protocol, which is a test battery which includes several tests of the CNTB that I just showed you, but also the cross-cultural dementia screening developed in the Netherlands, and some of our own tests, such as the NAME and the literacy screening test. And we really focused on tests that were widely applicable, as I mentioned before. And so what we did, we examined how often we could administer these tests and how often we had to discontinue with testing because it didn't prove feasible. And also whether secondary influences to neuropsych assessment were present, which are things like suboptimal effort, fatigue, pain, etc. We also did a community consultation, and we found actually that we need to think about a lot more stuff. So for example, some patients may wear a watch, but they never learn to read the time in the clock reading test. So that's important to know. Also, they commented that time pressure is an issue to them. And one of the tests had some issues where it was still relatively highly influenced by education. And what we found is that the test battery was quite long and only a subset of the test was administered. And about 9% of the patients at some point refuse to continue. I'll probably skip this and this one given the time. A remaining gap, I think, is cross-cultural aspects of social cognition. So we know that emotion recognition and theory of mind is highly impacted by culture. And this is shown in a very interesting study where they actually found that tests such as this emotion recognition test are most applicable when you're using them in England, where they were actually developed. And you can see large differences in the way these emotions are classified between different countries. So we currently have a PhD student in co-supervision with a center in Paris, where we're really trying to figure out whether there are opportunities to study cross-cultural social cognition, or whether that's a very culture-specific thing that is really not generalizable at all. So hopefully you'll hear more about her work later on. A tiny step into dementia prevention. So I was personally responsible for a dementia education program about healthy aging, in which we collaborated with nurses from different backgrounds who were really a part of the local communities. And we did like a 10-week course where we included lessons about basic human anatomy, for example, putting organs in the right place on a model, and also learning about healthy lifestyle, mental health and well-being, dementia, terminal illnesses, but also health literacy in general. So they, for example, could ask or practice asking questions with the doctor in the room present in Dutch. And also they were learning skills, how to look up information, given that they have low literacy. And what we found is that there is generally a limited dementia awareness. So I had someone say that, oh, my mom is in the early stages of dementia. She just doesn't recognize me sometimes. So it was quite clear that this was really necessary. And I think I showed you this photograph before. We really try to go into the community. So that means going to the local mosque during Ramadan to provide that education in the places where we can find these people. We also applied for funding for a new trial that we hope will be granted to us sometime this year, where we're really trying to design a dementia prevention trial specifically for individuals with low socioeconomic status and or migration background. And we're hoping to use qualitative research practices to inform this quantitative RCT. Really look into selecting widely applicable outcome measures like the ones that I showed you earlier. And also really to make sure that we design a study so that it will really lead to an adequate enrollment of diverse groups. And maybe some of you have already seen my paper in Alzheimer's and Dementia a little while ago about the impact of eligibility criteria on the enrollment of diverse participants. So it's a good thing, I think, to keep in mind. So in general, cross-cultural neuropsychology in Europe has really made some progress, but a lot of collaborative efforts are needed, including collaborations with diverse communities itself to really progress, I think. And our European consortium will obviously help with that, even though we have a long ways to go, for example, in the area of social cognition. And I just wanted to mention, if you are working in cross-cultural neuropsychology, I'm happy to announce that we will very shortly have a special issue in JINS about cross-cultural neuropsychology that I'll be guest editing. So if you're interested in that, just shoot me a quick email. And I think that's it in terms of time that I have. So no bonus materials for you, but I hope to have given you a brief overview of the work that we've been doing. And please feel free to reach out to me either directly or through Yakil or Ed-Marie to hear more about the work we do.
Thank you so much. You're doing really amazing work.
Thanks.
So please add your questions and comments to the Q&A. And yes, feel free to do that now. And while you write your questions, I actually have a question for you. I'm curious if you've been able to look at how using an interpreter may impact the scores, or if these are tests that could actually be easily administered through an interpreter.
Yeah, so I think in general, we've really tried to really use as many tests as possible that are easy to administer with an interpreter present, which also means that it can be quite hard to assess patients with visual impairments because a lot of the material will be visual. And I think there's some, like especially language tests can be really hard to do well with an interpreter there. For example, a while ago, I saw a patient with a Cantonese speaking background who I was 100% sure of had PTSD, definitely, because he had all the symptoms. And yet he also had some really strange difficulties in describing specific things. For example, he used to be a chef. And when we were doing a verbal fluency with food items, he could not really name a specific item because he kept on circling around the word. And it's just so hard to figure out what is actually happening in their minds, you know, because I can't hear what he's discussing with the interpreter, and the interpreter doesn't really have the jargon available to convey to me what is going wrong. So he can tell me, I don't understand what he's saying, but it's hard sometimes to find the words for that. And I do think it helps that we train many of our interpreters. So that makes it easier. We tell them what to listen for in language as well. Yeah, so that would be my answer. Language is probably the hardest to assess with an interpreter.
Okay, and we have a question. Could you comment on some of the qualitative indices you are considering for RCT?
Yeah, so I think what we are hoping to do actually is not just use qualitative methods to, for example, develop tests, but also just to determine what the intervention itself should look like. So do people want to use something on a mobile phone? Do people want to go to a person to hear more about a healthy lifestyle? How are we gonna really have this intervention itself take shape? And I do think that developing tests in collaboration with people from the communities is actually a really worthwhile effort. Because when we did the community evaluation, we already developed some of it. And I wish we actually consulted them earlier, because then they could have probably pushed us a little bit more into a direction that was more ecologically relevant to them. So I'm hoping to pick a few people's brain, for example, about the issue of how to measure attention well in a way that really has people motivated to do things as fast as possible.
I love that approach. I think it's going to be really effective. Jaquel asks, are you involved with any efforts of adopting your novel measures for remote assessment? So teleneuropsychology.
It's an interesting question. I think, so in the Netherlands, we don't really have that problem of rurality because there's very few rural areas that we have here. And a lot of patients of ours are not really e-literate. So they're not really like digital. Their digital literacy is really low generally. So I have a lot of patients who, for example, they can only access the internet if people send them videos, for example, on YouTube. So the way that they gain knowledge about dementia is just clicking YouTube videos and just clicking for the next video and not really typing anything. So I think remote assessment is a challenge in people who are really not accustomed to working with computers or digital technology. But I do think it could be something that is worthwhile in the future, given that more and more people are becoming used to working with those materials. And I know, for example, in Africa, they're doing quite some studies in neuropsychology using tablets and scoring remotely. And I do think, especially with somewhat younger populations, that there are avenues to do that.
Thank you. And Priti, thanks you for answering the first question. So we have another question. Are there specific patterns you have identified on verbal fluency tasks, both semantic and phonemic, that are unique to the different populations you work with? For example, do you find that certain populations, depending on their alphabet or native language, perform differently on verbal fluency tasks aside from the challenges associated with using an interpreter on time measures?
Yeah, I actually did a lot of not published research into this area because the findings that we had were not very conclusive and not very good, I think. So, for example, we did some work looking at clustering and switching analyses of verbal fluency, which is something that is being done more and more often, where you look at the number of items people name within, for example, a specific animal category, let's say zoo animals, pets, I don't know, like reptile, all sorts of different categories, and you look at how often they switch and how big the categories are. And we try to do some analyses of those in different patients with very different diverse characteristics. But we actually found that fluency was not very helpful in predicting dementia at all, which was not as we had expected at first, because you would think fluency is a very sensitive measure to cognitive decline. And we were hoping that these additional measures may be even more beneficial. And I think there may be a lot of different reasons why we didn't find a good connection between the two. So it could be that the diagnosis is still really difficult to determine and be 100% sure of in these populations. Like I had with my patient with PTSD, I wasn't sure if that was the only thing that was happening. And I think it's also part of not really knowing what people have been exposed to in their daily lives. So I know my colleague from Denmark, he sometimes in workshops asks people to name as many car types as they can come up with. And obviously it really depends on the experience that you have in everyday life. That is not very easy to capture in data. So even though I love verbal fluency as a general measure, I find that it's quite hard still to find some good patterns or psychometrics that we can extract from the qualitative data that people have given.
Very interesting. I'm
not sure if it answers the question, but
if Jennifer has any follow-up questions, please feel free to write it down. But she says thank you very much. So I think you did answer the question. I'm curious if you have looked at measures of effort in these multicultural samples, and if you have, how, what you've noticed.
Yeah, that was part of our feasibility study. Actually, those were the two slides I skipped, so I shouldn't have skipped those probably. But yeah, so one of the measures that we added, because we know that a lot of the performance validity tests that are currently being used worldwide are not very suitable for diverse populations. So for example, the test of memory malingering, but also some of the other tests, they can show a lot of false positives in people who are just participating as controls and have no ulterior motive, no reason to show performance validity issues. And so we used the coin in the hand test, which is supposed to be a bit better and a bit more robust, given that it makes use, you should look it up, it's really interesting. It uses a coin and you distract people like a magic trick, and then you ask them which hand the coin was in, and it's the same as it used to be. And people think that's a very difficult test, but it's clearly not. And we actually found that we had some quite substantial numbers of patients in our clinic who would fail these performance validity tests. And we were actually also quite shocked, I think, by the levels. So they were in the tens of % of people to whom we administered those tests. And in our study, we also found that we had a very large share of people who showed symptoms of depression, but also who displayed fatigue during testing, both visibly, but also commenting that they were tired or they were having headaches. So I think what we're still currently doing and working on is trying to figure out which patients we should assess with a full neuropsychological assessment and which patients perhaps should just receive a screening tool in addition to, you know, other biomarkers. So that's one thing that we're currently actually working on, is trying to set a cutoff score for different screening tools, perhaps, to find out who to refer for a full neuropsych assessment.
I was not expecting those numbers, but that's really important for us to keep in mind, especially because a lot of us work with diverse populations and often use some of these measures. So it's good to keep that in mind. So we don't have much time left, but if anyone has any questions, please feel free to ask it now.
Yeah, maybe one good comment to that is a low performance on a performance validity test doesn't obviously mean that someone is not trying, but it may also be that people aren't getting what you're asking of them. Or so I don't want to, you know, judge people who fail performance validity tests, but it's an issue sometimes.
Yeah, no, that's a really good point. So thank you so much again for your presentation. I really enjoyed it. I can't wait to be able to use these measures in a clinical setting. Your work is definitely very, very important. And so I'm glad we got to hear about it today. And
yeah,
so
and if you
thank
need
you,
any
everyone.
materials, a lot of materials are freely available from me, so please email me.
Wonderful. Well, thank you everyone for coming today, and then we'll see you next month at our next MAPP Rounds. All right. Have a good day, everyone. Bye.